Hello everyone, this is the Cancer Screening and Prevention module for the BCOP certification program from HOPA. My name is Dr. Robert Mancini. I currently serve as the BMT Pharmacy Program Coordinator and PGY2 Oncology Residency Director at St. Luke's Cancer Institute in Boise, Idaho. I have only one disclosure, that's for the Speakers Bureau of Takeda Pharmaceuticals. However, that's not necessarily relevant to this presentation. Our learning objectives today are to outline the various modifiable and non-modifiable risk factors associated with a multitude of oncologic malignancies, use available data to provide recommendations for various pharmacologic and non-pharmacologic interventions in cancer prevention, and differentiate cancer screening recommendations from national guidelines for general versus high-risk populations. It is important to note that there is a lot of detail in this presentation and we need to get through all of it in an hour. So I've called out specific details in the slides today. However, I will reference and let you know when to go to the handout for more specific information throughout the presentation, as well as an expansion of the information presented today. So in order to better understand why screening and prevention is so important, it's important to look at the landscape of cancer in the United States today. It is estimated that there was 1.7 million new cancer diagnoses in 2019, with over 600,000 deaths due to cancer. It is also estimated that 42% of newly diagnosed cancers are potentially avoidable, with about 20% related to smoking and another 20% related to diet and lack of physical activity. Within that, lung cancer has the highest preventable cases and deaths, followed thereafter by colorectal cancer. And the direct medical costs of cancer care are estimated, or was estimated, to be about $80.2 billion in 2015. Therefore, it's important to understand that hopefully with a better interest and expansion of cancer screening and prevention techniques, that hopefully we can decrease the direct medical costs of cancer care going forward. So prevention is defined as the reductions in cancer mortality by means of reductions in the incidence of cancer itself. And there are multiple ways by which we can do that. First is by avoiding carcinogens or altering their metabolism, pursuing lifestyle changes, medical interventions such as chemoprevention, and early detection and removal of precancerous lesions. And we'll go through some details later in the presentation today. Prevention strategies are derived from epidemiologic studies that show an association with risk factors. So it's really important to note that if you can understand the risk factors and how to address them, that's the best prevention method that we have. And so while there are no solid direct links, with a few exceptions, this is really important to know that there's a cause and effect relationship. And so while we may see some examples of how, there's an epidemiologic relationship, we have yet to see definitive evidence that some of those interventions have proven to actually reduce the risks or incidence of cancer to date. And I'll show you some examples as we go through that. So there are some risks, as mentioned, that are causally associated with cancer. And first is cigarette smoking or tobacco use. And this has the most substantial body of evidence linking the association. And it is a known cause of at least 9 different cancer types. Within that, it is estimated that cigarette smoking or tobacco use can cause about 30% of all cancer deaths. Another contributing factor is infections, and we see a higher burden of infectious-related cancers in developing nations at about 26% compared to those in developed nations such as the US, which is down to 8%. However, if you average that out, it's estimated to cause about 15% of all cancer cases globally. The next cause is radiation, either ultraviolet radiation or ionizing radiation. What we do know is there is no known dose of radiation that's considered completely safe, and CT scans of the different types of imaging tests that we use are potentially the most damaging. Next is environmental exposure and pollutants, and there's lots listed there, such as air pollutants, which is associated with lung cancer, asbestos, which is associated with mesothelioma, arsenic exposure, which is interesting because we do use that in treatment of certain diseases such as APL, and pesticides. However, with pesticides, we don't know exactly the association because it's really hard to study kind of a direct link in exposure because most people don't know the degree or the extent of that direct exposure. And then last is immunosuppression, whether that be congenital or acquired immunosuppression through our treatments of these patients. As I said previously, as we'll talk about, you'll see some associations, but the data is mixed. So there are some studies that suggest that these may be associated with cancer. Others suggest that they don't see that same degree of association. So we'll talk about a lot of these, and there's a lot of data and information going into some of these in terms of studies. However, we can say there is a possible association, but because the data is mixed, we have to be really careful about how we link those causally. So first is diet, and again, data is variable, and it may be more related to a group of changes rather than just the diet itself. So rather than saying, hey, this food causes cancer, it may be more associated with the fact that people who have other risk factors, such as lack of physical activity or obesity, also have poor diets, and therefore you see that association. Alcohol consumption is convincing in certain types, but only probable in others, and we'll give some specific examples of that. Physical activity, we do know that more physically active people have a lower risk of certain malignancies than sedentary people. However, that link is not well established, and we'll talk about some examples as we go through the guidelines. Obesity, again, some studies suggesting association between body mass index and certain cancers, and diabetes being the more recent association that we've seen, has concomitant risk factors, again, like diet, physical activity, obesity, that may be causally associated. However, we do know that patients with diabetes have a much higher risk of mortality if the cancer actually develops. So cancer patients with diabetes have a higher risk of mortality secondary to cancer than those who do not have diabetes at the time of diagnosis. So what is the role of the pharmacist? The oncology pharmacists, as we all know, are vital members of the cancer care team and can assist in prevention throughout that process. So what we can do is focus on education on risk factors, as well as primary and secondary prevention, and counseling on adherence and the use of chemoprevention. There is some objective impact studies in terms of how we can do it, but they're not directly related to cancer itself. They're related to some of the risk factors, such as smoking cessation. But overall, the role of the pharmacist in cancer screening and prevention, we don't have a lot of good studies, and so more research is needed desperately. And I really encourage us as oncology pharmacists to take the helm and make this a huge focus point going forward into the future. So now I'm going to talk a little bit about the various types of cancers and whether or not we know if there are any particular risk factors or known prevention methods. And so all the information on the next few slides is pulled collectively from individual NCCN guidelines for the specific disease states. So starting with cancers with no known prevention, these are cancers, and I'm not going to read through everything on this slide, but these are cancers that are mostly related to either genetics, family history, age, or ethnicity, or we just don't have any well-established associations. And you can see a lot of these are either CNS-related diseases or diseases that we see in pediatric patients. Next up is cancers with potentially modifiable risk factors. And when I say potentially modifiable risk factors, I mean risk factors that are mostly exposure related, but may or may not actually be modifiable. And this can include stuff that patients may never have known that they were exposed to, such as radiation, environmental carcinogens, certain infectious diseases, as well as past chemotherapy exposure. Yes, patients will understand that, but to treat their previous disease, that may be something that's required of them. And as such, they take on that known risk at the time of initial treatment with chemotherapy. So again, a lot of what you see here tend to be those are the connected tissue, leukemias, lymphomas, sarcomas, those kind of things tend to be in this group of diseases. And the next group are cancers with modifiable risk factors. So again, I laid out all the different diseases and I gave you some annotations. So again, if you go to the handout, you'll get more information on the specifics of each of these particular diseases. But one I like to point out is either these risk factors that we know are either alcohol related, comorbidity related, such as diabetes, as was previously mentioned, diet related, exercise related, infection related, medication related, obesity, smoking, or UV exposure. Now, to give you some examples that I call out throughout this, if you look at something like ovarian cancer, for example, so you'll see the M next to that, and that's medication. And so we do know that the use of postmenopausal hormone replacement therapy, as well as fertility drugs, can increase the risk of ovarian cancer. Another one that I like to point out is cervical cancer. So cervical cancer has the I and the S. So I for infection or HPV, and S being smoking related factor. Then you look at something like bladder cancer. So you have bladder cancer in terms of medication. And again, we know that previous exposure to chemotherapy such as cyclophosphamide can increase that risk. So these are just some examples. Again, you can get more information from the reference handout for the different causes associated with each of these cancer types. So it is important to note that the patient's education and the general public's education on cancer risk is an important starting point for us to understand where we need to go. So in 2017, the American Institute for Cancer Research, or AICR, created the Cancer Risk Awareness Survey. Within this, they surveyed about 1,000 respondents in the United States and were asked about potential risk factors. Some of the interesting findings that they saw was about less than 50% recognized that inactivity, alcohol, diet, and processed meats could be risk factors. 50% were unaware that obesity could be a risk factor, while greater than 50%, or more than half, believe that stress, beef hormones, and genetically modified foods can lead to cancer risk, and this has yet to be proven in any large-scale study. Many believe that sugar and high-fat diet cause cancer. We've heard that. We all hear about the sugar or eating sugar feeding the cancer and increasing the risk and the progression of cancer, which again has not been proven true. 4 in 10 recognize that alcohol does increase cancer risk. Only 1 in 10 knew that coffee can lower the risk of endometrial and liver cancers. So for those of you who are coffee lovers, you may get some benefit there. Again, everything in moderation. The overwhelming majority did correctly identify that tobacco and UV exposure can be risk factors as well. So you see some areas and potential areas for education opportunities that we can provide as pharmacists as well as healthcare professionals. So let's jump into the information on cancer prevention as well as the studies that are associated with that. So first, in order to do this, I think it's important to understand the various guidelines that exist in terms of cancer prevention and what they provide and when they're best utilized. First is the National Cancer Institute, or NCI, Physician Data Queries, or PDQs. This can be found at the website listed. These provide patient and health care professional guidelines, which includes cancer prevention overview, which is a really nice overview of all the different things to consider when looking at cancer prevention. They have information on tobacco cessation as well as disease state-specific interventions. It also outlines within each of these guidelines the study design and evaluates those studies for both internal and external validity. So in my opinion, it is one of the most thorough evaluations of studied interventions that are compiled for specific disease states as well as cancer prevention overall. Next is the American Cancer Society, or ACS, and their guidelines can be found at the linked website there. They provide guidelines on nutrition and physical activity for cancer prevention, as well as for healthy weight, physical activity, diet, and alcohol intake. It is important to note that ACS also outlines information on food additives such as hormones and sodium nitrate, food irradiation such as sterilization and GMO. And they been able to demonstrate thus far that there is no associated risk factors in those groups of medications. It's interesting because this is actually one of the guidelines that has been studied in a trial. So the Guidelines on Nutrition Physical Activity for Cancer Prevention was studied in the NIH AARP Diet and Health Study. And they found that those with the highest adherence scores to those recommendations had statistically significant reduction in all cancer incidence, cancer mortality, and total mortality compared to those with the lowest adherence. Next up is the American Institute for Cancer Research, or AICR, which we mentioned briefly before. Again, information can be found at the linked website above. So they produced a report called The Diet, Nutrition, and Physical Activity in Cancer, A Global Perspective, and they've actually released the most recent in 2018, which is the third iteration of this guideline. And what it is, it's the world's largest and most authoritative and up-to-date source of scientific research on the topic. And the recommendations are pretty similar to the American Cancer Society with 10 primary recommendations, which I'll show you on the next slide. There have been 4 different studies evaluating the adherence to these guidelines and cancer risk. So the Nutrinet Sante cohort, they looked at overall cancer risks with those with the lowest adherence and highest adherence having a statistically significant difference, especially in patients with breast and prostate. So breast and prostate in this study seem to have the best reduction in cancer risk compared to those who didn't adhere to the guidelines as well. The Chances Project gave each additional point for adherence to those guidelines was associated with a lower risk of total cancer, and as well as postponing cancer incidence at any site by 1.5 or roughly 1.6 years. The Kohler study looked at adherence to the guidelines and found that they significantly associated with a decrease in overall cancer, colorectal cancer, breast cancer, and endometrial cancer. And then last was the Lowe study, which estimated that about 13% of premature cancer deaths could be prevented with better adherence. So again, we now have this guideline that's been studied in multiple large-scale studies to show that higher adherence, again, this is where we start to look at the fact that diet, nutrition, physical activity, which was previously mentioned as probable but unclear, may be not just one individual thing, but again, the more they adhere to the various components, which is all 3, diet, nutrition, physical activity, all of those things combined, the better your overall lifestyle in those parameters, not just individually, but as a group, may decrease the risk of cancer. So as I said, the American Institute for Cancer Research has these guidelines. I'm not going to read all of them. You can kind of read through these on your own, but this is a really nice graphic that they put out. Again, you can find this on the website listed below or on their website at aicr.org. But you can kind of see the different recommendations that they provide. So 10 different focuses on diet, nutrition, and physical activity. And again, they're all linked to, again, the consumption as well as how you eat, what you eat, and the importance of maintaining a healthy weight. Moving on to the next set of guidelines. First are the World Health Organization, or WHO, Cancer Control, Knowledge into Action Guidelines for Effective Programs. And again, websites listed there. These outline the worldwide risk factors and how to implement risk reduction programs. So it's a really good opportunity if you're looking at how to implement a program within your institution or where you work, depending on your geography within the US or beyond. And it really focuses first on tobacco, which, as was mentioned, is the single greatest avoidable risk factor worldwide, but also gives ideas on how to implement nutrition, environmental and occupational contaminant radiation exposures, as well as infectious causes. So really the WHO guidelines are really focused on how to implement programs that can serve your population, whether you live in a developed or undeveloped country, and it can really help you guide opportunities, not just at the local level, but really push for larger scale governmental implementation of various program types. Then next is the National Comprehensive Cancer Network, NCCN Breast Cancer Risk Reduction Guidelines. Again, these are really focused on breast cancer, obviously, by the name. but look specifically at risk reduction interventions. This includes lifestyle modifications, genetic counseling recommendations, and medical interventions such as prophylactic surgery and/or medications. After that, we have ASCO or ASCO, American Society of Clinical Oncology. They do have a couple cancer prevention guidelines, but they are limited to specific topics. That includes 5-alpha reductase inhibitors for prostate cancer chemoprevention, pharmacologic interventions for breast cancer, primary prevention of cervical, and then secondary prevention for survivors of colorectal cancer. So if you're looking for very specific guidelines on these topics, as well as a nice outline of the data associated with them, ASCO would be the place to go. And then last is the USPSTF, which is the United States Preventative Services Task Force. And they focus on recommendations more for the primary care provider population, as well as the general population, not necessarily the high-risk population. So they do have a couple guidelines. First is aspirin for the use of colorectal cancer risk reduction. They do have a breast cancer similar to ASCO or NCCN risk reduction. They include skin cancer prevention, focusing on behavioral counseling, and then a tobacco cessation guidelines. As we'll talk about not only future going forward in the prevention section, but also again in the screening section, you'll notice that USPSTF really focuses on cost-effective interventions. And so when we look at some of the guidelines, you'll notice that USPSTF tends to focus on very, very conservative recommendations where only situations where there has been a proven cost-effectiveness benefit in terms of either outcomes or mortality. So keep that in mind as we move forward through the rest of our guidelines here. So based on that and kind of compiling all the data that we saw in those various guidelines, I created this nice little handout. And again, you can go to the reference handout for more specific information on each of those. But within those guidelines, you can pull piecemeal components of that. But there are cancers with known and documented prevention measures. And those measures can include chemoprevention, lifestyle modifications, surgery, and/or vaccinations. And so again, if you look here, there's 13 different cancer types that have recommendations on preventative, known or proven preventative measures. So I'm not going to go through all of these, but some examples. So breast cancer. So I put C, chemoprevention. So we know that aromatase inhibitors and/or tamoxifen and the associated medications, which we'll talk more about, can have effect in prevention of breast cancer. Lifestyle changes such as early pregnancy, breastfeeding, exercise, as well as decreased exogenous estrogen use can also, all of those combined can decrease risk of breast cancer. And then S is surgery, right? So there's plenty of examples out there, and you probably all know patients as well as famous people who have had prophylactic mastectomies because of their associated high-risk features such as being BRCA positive or something of that nature. Another one that's kind of interesting is the liver cancer or hepatobiliary cancer. So we noticed that the L, so lifestyle modifications, so avoidance of aflatoxin contaminated foods, as well as vaccinations. So we do know, and we'll talk about briefly, the association with hepatitis B infection in the hepatobiliary cancers, as well as the associated decrease in risk with hepatitis or appropriate hepatitis B vaccinations. So let's jump into some of the data on the non-pharmacologic interventions. So the first one, and this is a huge soapbox of mine, but I won't go into that for purposes of time during today's webinar. But first is smoking cessation. And if we look again at the statistics, so pulling back from one of those first slides, about 19% of all cancers are associated with either smoking or tobacco use. And if we drill down into lung cancer, we know that about 81% of lung cancer deaths are associated with smoking or tobacco use. And overall, if we add all the different types of cancer that exist, we know that about 30 to 40% of all cancer deaths across the board are associated with tobacco or smoking. The other things that we do know about smoking is that smoking during treatment can increase the risk of treatment failure as well as risk of complications. However, it is kind of interesting, not that I'm trying to promote smoking in any way, but I think it's important to have the information and know in case this comes up in a conversation with a patient or their healthcare provider. But we do know that smoking or tobacco, possibly related to nicotine or some other product in the actual tobacco, can actually decrease endometrial cancer risk by about 20%. So again, it's interesting to know, but I wouldn't use that as an argument for smoking by any means. So there are some studies looking at cessation benefits. So we do know that smoking cessation at any point has benefit. And so in the context of lung cancer, smoking cessation decreases the incidence of lung cancer up to 50% within 10 years of smoking cessation. However, there's mixed data, and ultimately we don't know if that risk ever returns to baseline compared to someone who never smoked. You may see it get almost minuscule, but there's nothing to say definitively that the decrease in lung cancer is similar to a non-smoker at any given point after smoking cessation. With head and neck cancer, we do see a decrease at about 1 to 4 years after cessation of about 30%. And after 20 years of cessation, we actually do have data that suggests that head and neck cancer risk equals that of a never smoker within 20 years of cessation. We also do know, and the data is not as solid, but we do know that cessation can decrease the risk of stomach and bladder cancer over time. And the farther you get out, the more from smoking cessation, the more benefit that you see there as well. So what do we do about smoking cessation? So there are 3 major guidelines. So ASCO, NCCN, USPSTF all have guidelines focused specifically on smoking cessation in the context of cancer prevention. So ASCO tobacco control agenda unfortunately hasn't been updated since 2013, but their focus is to call for better access, i.e. pharmacists. No, I'm not sure they called that out specifically, but as we know, we can be one of the most accessible as well as have really good training on smoking cessation. Call for better education as well as funding in tobacco control. So they do have a nice guideline called Tobacco Cessation Guide for Oncology Providers. And so that's a really good option to look at in terms of bringing that into your practice as a way of developing a smoking cessation opportunity in your practice if you don't have something tied to your cancer programs. In ASCO, most importantly, again, this is part of my soapbox, is they really encourage leading by example. So us as healthcare providers, especially us as oncology providers and pharmacists, we really should not be using tobacco because we need to lead by example. And one of the best things we can do is be able to provide our own experiences, but also not to say, hey, you need to do this when we're not doing it ourselves. So the NCCN guidelines last published in 2015, they had pharmacologic therapy as the focus of their intervention techniques because it's been proven to be both effective and it's highly recommended by multiple guidelines, not just NCCN. So they call it the best option for smoking cessation as dual therapy with nicotine replacement as well as varenicline or Chantix. They combine pharmacologic intervention with counseling, and they encourage that providers document smoking status as well as changes and progression towards smoking cessation thoroughly within the patient's chart. So each time you see a patient, each time that you interact with them in clinic, whether it be in a primary care clinic or within a cancer clinic if they are one of your patients, that be documented what their current status is, what progress they've made if they're a previous smoker, and if they have had any failures. And really, if they have had failures, the guidelines encourage these patients and you as healthcare providers to really support those patients. So rather than chastising them or giving them a hard time about their failure, try and figure out what happened and help guide them through and encourage them to try again. USPSTF, and they have the most recent guidelines last updated in 2019, and their recommendations not surprisingly, suggest that adults should be advised to quit and provide both behavioral and pharmacotherapy based interventions. And this is a grade A recommendation, which is their highest level of recommendation. For pregnant patients, they encourage a focus on behavioral interventions only because they do not encourage the use of any type of medical intervention in patients who are pregnant. And they do actually call out something that hasn't been addressed thus far, which is the use of e-cigarettes or vaping as a method for quitting. They don't say don't do it, but they don't say that it helps because the data is essentially ineffective or insufficient to be able to make that statement. Now, I know we've all had patients, and many of us have heard stories of people who claim that vaping has helped them quit. But again, we don't know the associations, and we're seeing more and more problems with vaping, but we don't know if that benefit of smoking cessation or tobacco use cessation offsets the risks associated with vaping itself. So next in the non-pharmacologic interventions is sunscreen and UV protection. So skin cancer is the most commonly diagnosed cancer type overall, and the incidence is rising. So we know that there are about 4 million cases annually for all skin cancer types. And we do know some of the reasons for that, with tanning bed use associated with about 450,000 cases in skin cancer each year within the United States. And the attributable risk between tanning bed use and non-melanoma skin cancers is about 3% in never users versus 21.8% in ever users. So anyone that's used a tanning bed can potentially have almost a 7-fold increase in risk of non-melanomatous cancers and about a 3 to 4-fold increase for melanomatous cancers. So regular use of sunscreen versus, say, discretionary use. So every time I go out into the sun, I'm going to put sunscreen on versus, oops, I forgot, I'll do it next time, kind of situation has reduced the incidence of cancer. And so there are some studies that show that regular use of sunscreen, again, putting sunscreen on regularly and or other clothing or other things that protect your skin can reduce new melanomas by about 50%, as well as squamous cell carcinomas by about 40%. However, we haven't seen an association or significant benefit in this use for basal cell carcinoma. And that may be related to the fact that basal cell carcinoma is more directly related to cumulative exposure, and follow-up in trials are not sufficient at this point. And so because it's a cumulative exposure as opposed to like a one-time burn that we can sometimes see with melanoma or squamous cell, then that may be associated with why we're not seeing that big difference. If you look within the guidelines, there's different things that say, some say use a minimum SPF of 15, some say 30, but essentially 15 is the absolute minimum. You will see some guidelines say really you should be about SPF 30 is what's, quote, recommended, but 15 is the minimum. And the difference is really, so SPF 15 filters about 93% of UVB, whereas SPF 30 filters about 97%. So you're looking at about 4% difference. And so that's why there's a little bit of discrepancy in terms of what's recommended there. So here are the American Cancer Society recommendations for skin cancer or skincare. And the American Society recommendations, first and foremost, avoid direct sun exposure between 10 a.m. and 4 p.m. when UV radiation is the most intense. And those numbers are just rough estimates trying to average out across the globe, which is close to impossible, but that is really the time point where the sun is highest in the sky, and therefore the direct sun exposure and UV radiation is most intense. They also recommend avoiding tanning beds, and then they have these 4-point guidelines, which, you know, I think is somewhat interesting in my perspective, kind of funny, I guess, because it's not necessarily how I would apply a lot of these things. But their guidelines are slip, slop, slap, and wrap, which is slip on a shirt, slop on some sunscreen, which again, you know, you should probably not just slop it on, but, you know, put it on in a methodical manner. Slap on a hat, and then wrap on some sunglasses. And again, I'm not going to read all the details. You guys can read that. And these are in the handout as well, so you can get the specifics of those guidelines. So moving on to pharmacologic interventions, the first one that I want to talk about is the human papillomavirus, or HPV vaccination. And so HPV is the most common sexually transmitted infection in the US, with the inability to clear the virus more associated with the risk of cancer than ever having it. And so what we do know is those, a lot of people who get or are exposed to HPV may never have cancer. And there is a difference in what they're discovering in patients who get the virus and are able to clear it, have a much lower risk than those who get the virus and are unable to clear it completely from their system. It is associated with several types of cancer, including cervical, oropharyngeal, anal, vaginal, vulvar, and penile cancers. And it is strains 16 and 18 that are most commonly associated with the development of cancerous lesions. There are comorbid conditions that increase the risk of developing HPV-related cancer, including tobacco use, immunosuppression, poor oral hygiene, and chronic inflammation, all increase the risk of HPV, likely because they're suppressing the immune system in some way and not allowing the body to fully clear the virus after an infection. The HPV vaccination is FDA approved, but only for use in the prevention of genitourinary and anal cancers, is not yet FDA approved for the prevention of head and neck cancers, even though we do know of the association. And HPV vaccination is most effective if given before the initiation of sexual contact. So looking at the vaccination, so HPV vaccination along with appropriate screening has reduced morbidity and mortality associated with cervical cancer. So currently there's only one, the 9-valent, but previously, and a lot of the studies come from the previous versions of the HPV vaccine, whether it be the 2-valent or the 4-valent. And those studies have shown that it can reduce the incidence of CIN, which is cervical intraepithelial neoplasia, which is the precursor lesion to cervical cancer, as well as adenocarcinoma in situ, from a baseline of 3.6 all the way down to 0.2%. 4-valent studies have reduced various types of cancer upwards and pre-malignant lesions upwards of 89 to 100%. And studies with the 9-valent have shown that they've further reduced HPV-related disease from 0.16% to 0.01%. So if you look at it from that perspective, we're really cranking down the incidence, not only of HPV-related cancers, but other HPV-related diseases as well. And again, as I said, strains 16 to 18 cause about 70% of cases. However, this expanded coverage with the 9-valent expands the coverage up to 90% of cases associated with HPV. And so adding those extra strains or the extra versions of the HPV virus itself within the vaccine has greatly increased the coverage of vaccinations. It is important that to note that new recommendations from the CDC states that 2 doses of the HPV vaccine are is not inferior, in some cases superior, to the 3-dose regimen for HPV, and therefore has changed its recommendation such that those who start prior to the age of 15 or start the vaccination series prior to the age of 15 should receive 2 doses, while those who start later, such as age 15 to 26, or who are immunocompromised, should still get the 3-dose regimen for optimal protection. So this kind of restates what I just said. So children started at age 9 to 14 years get the 2-dose series about 6 to 12 months apart. Children started at age 15 to 26 years or who are immunocompromised get the 3-dose series at 0, 1 to 2, and 6 months. Adults 26 to 45 get the full series regardless. And then the 9-valent vaccine, like I said, is the only FDA-approved agent currently available, and the strains that it expands to are listed there. However, and most importantly, as we'll talk about when we get into screening, the use of vaccinations does not change screening recommendations. So even though someone has been vaccinated for HPV, it's really important that they still undergo the routine screening methods that we'll talk about in the last half of this session. Next is the selective estrogen receptor modulators, or SERMs, in breast cancer. And both tamoxifen as well as raloxifene have been studied for breast cancer risk reduction. Tamoxifen studies have reduced the incidence of breast cancer in postmenopausal women as well as high-risk premenopausal women, with that reduced risk of about 30 to 50% over 5 years. But that's only for ER-positive cancers as well as ductal carcinoma in situ or DCIS. What we have seen is that the effect in terms of breast cancer risk reduction persists for several years after the treatment is discontinued. And based on current studies, we know that's about 11 years of benefit after the cessation of tamoxifen. Raloxifene has only been shown to reduce incidence of breast cancer in postmenopausal women, and that effect, similar to tamoxifen, does persist for several years after treatment discontinuation. However, we don't know the exact duration, and it's not, but we do know it's not as long as tamoxifen. So tamoxifen still tends to be the preferred regimen in terms of breast cancer risk reduction. If you compare the two, tamoxifen has been shown to be better for prevention with a relative risk of 1.25 of developing breast cancer for raloxifene compared to tamoxifen. But raloxifene has been shown to be better tolerated, so relative risk of adverse events lower compared to tamoxifen, and that focuses mostly on either VTE risk or development of endometrial cancer, both of which are higher with tamoxifen. After the SERMs comes the aromatase inhibitors for breast cancer again. And so they've all been studied in different versions. So exemestane has been shown to reduce risk of new breast cancers in postmenopausal women with an increased risk. So that was defined as women 35 years of age with at least one risk factor. So that includes being older than 60 years of age, Gale 5-year risk score of greater than 1.66 or 1.67, depending on where you look, %, or DCIS after mastectomy. So they looked at the dosing of 25 milligrams of exemestane, and that decreased the risk with a really positive hazard ratio of 0.35 decreased risk at 35 months of therapy. And the number needed to treat is about 94 and 26 at 3 and 5 years respectively. So within 5 years, you get a much greater benefit than using it for just 3 years. Anastrozole has also been studied and shown to reduce the risk of invasive and non-invasive breast cancers, and this was studied in the IVAS-2 trial. They looked at women 40 to 70 years of age stratified by risk over the general population, and they found that 1 milligram daily anastrozole decreased the risk at about 5 years. And again, number needed to treat is about 50 and 36 at 5 and 7 years respectively. So, you know, we always use caution in comparing two non-related studies, but you can kind of see the differences in number needed to treat with exemestane and anastrozole, suggesting that maybe a little more benefit with exemestane, but again, you can't kind of go from that just based off two separate studies. It is important to note that aromatase inhibitors are not currently FDA approved for the indication and prevention of breast cancer. However, if you compare aromatase inhibitors to the SERMs such as tamoxifen, we know that aromatase inhibitors are superior to the SERMs in terms of breast cancer risk reduction with less toxicity. However, because the SERM data is more robust, you're going to see some differences in what's recommended in the literature. So moving on to the actual guidelines. So I mentioned these guidelines earlier in the presentation. So NCCN breast cancer risk reduction guidelines. So the risk reduction therapies for women greater than or equal to 35 years of age at higher risk than the general population. And again, you can see those various guidelines, including family history, the Gale risk, previous genetic exposure, or previous versions of premalignant lesions. And again, those kind of things are important to note. We use this in those, the guidelines are focused in those over the age of 35. It's not to say that the benefit is not there in less than 35. However, it just hasn't been studied as frequently. So we can't definitively say those less than 35 will or will not get as much benefit as those over the age of 35. It's just where the study cutoffs have been. The options for risk reduction that they provide within the guidelines include bilateral total mastectomy plus or minus reconstruction, bilateral salpingo-oophorectomy with peritoneal washings, or you can treat these patients, and these all include category 1 recommendations, including baseline gynecologic assessments for women with a uterus, again, possibly because they're going to be going on to tamoxifen, as well as bone density, because you want to be able to assess their ability to tolerate estrogen suppression, as well as the potential for that long-term more with your aromatase inhibitors. For premenopausal women, they recommend either a clinical trial or tamoxifen in terms of the actual medical treatment. Or postmenopausal women, same thing, but they also include raloxifene or aromatase inhibitor within those recommendations. Other hormonal studies or other hormonal products that have been studied include oral contraceptives. And so oral contraceptives have been looked at in multiple different diseases, first being ovarian cancer. And we know that oral contraceptive use can decrease the risk of developing ovarian cancer by up to 50% after at least 5 years of use. And the longer a patient uses it, the greater protection against ovarian cancer that they will get. Similar to what we discussed with tamoxifen, the use of oral contraceptives has a protective effect that can last beyond discontinuation of the oral contraceptive itself. And the studies thus far have shown that you can get a benefit of up to 30 years after stopping an oral contraceptive. And studies have suggested that oral contraceptives have prevented over 200,000 cases of ovarian cancer and 100,000 associated deaths. And so we do have some pretty good data in that realm. We've also seen some benefit with oral contraceptives in endometrial cancer, which decreases risk by 50% or more. And the longer they use it, again, the greater the protective effect. There is some studies and smaller scale studies that suggest that oral contraceptive use does decrease the risk of colorectal cancer. However, there is that little caveat right on the edge of statistical significance, where we're always concerned about the potential increase in risk of breast cancer. Again, that is highly controversial, so I wouldn't fixate on that, but it's important to know that that data does exist and may come up in conversations with your patients. There's a couple of small studies that suggest that progesterone can reduce the risk of endometrial cancer in those with complex atypical hyperplasia. Moving on to aspirin and NSAIDs. So they decrease risk of developing or dying from esophageal cancer, and they do notice a difference between intermittent use and frequent use. And more frequent use, you get a more defined benefit in the prevention of esophageal cancer. And aspirin, as well as more frequent use, so greater than 10 years of aspirin, are associated with better effect. They have also been studied to show the decrease in risk of developing colon cancer, and that is dose dependent. So they suggest that regularly used, which is more than or equal to 2 tablets per week, reduces the risk of colon cancer. However, this study was primarily in women, and the benefit seen was primarily in colon, not necessarily rectal cancer. There's a strong benefit for the use of celecoxib, which is our COX-2 inhibitor, by those with patients with this genetic condition called familial adenomatous polyposis, or FAP. And they showed that doses of anywhere between 100 and 400 milligrams twice a day decreases polyp burden, anywhere from 15 to 30%, and in some cases may actually delay the need for prophylactic colectomy. USPSTF, as we mentioned previously in terms of their conservative nature, they do note that their use of aspirin or NSAIDs can reduce the risk if taken for at least 10 years. However, their recommendations say that they only recommend daily low-dose aspirin in adults 50 to 69 years of age for cardiovascular protection. So essentially what they're saying is if you're using it for cardiovascular protection, then hey, you'll probably get some benefit in the colorectal cancer realm, but that's not why you should be using it. You shouldn't be using it specifically for colorectal cancer. So another interesting one that's come out lately, and more data has come out over the years, is metformin. And so there are some epidemiologic studies that suggest potential mechanisms in cancer prevention. Now, we're not talking about the contaminants. That is a big topic of controversy right now that may be associated with an increased risk of cancer, but we're talking about metformin in and of itself. And so really, I just wanted to kind of lay out the data here, and you can see all the different studies that have been conducted. And as you can see, there's mixed data with smaller studies suggesting benefit, but as they start to put these together into larger randomized trials or even meta-analyses, that you're not seeing that same benefit. So I think it's interesting and something to know, but more to come on metformin and cancer risk. Next is vitamin D supplementation. So we do know that vitamin D deficiency is linked to breast, colon, and prostate cancer risk. That's been seen in many large-scale studies and meta-analyses in that there's a proven inverse relationship between circulating vitamin D levels and breast cancer risk. The study suggests that people can get adequate intake from natural dietary sources only, and as a result, UV-based exposure is not encouraged because of the antecedent or the concomitant risk of developing skin cancer from too much UV-based exposure. Large-scale meta-analyses have yet to show no benefit, or yet to show any benefit of supplementation in preventing cancer in the general population. So really important to know that while there is association between deficiency and cancer risk, it's probably more directly linked to a subpopulation rather than the general population. That's probably why we're not seeing that direct link to benefit in vitamin D supplementation in the general population. So if you're deficient, yes, maybe try it. If you're not deficient, then there's really no reason to push that. So as a result, the Institute of Medicine has provided a recommendation that vitamin D supplementation is still inconsistent and insufficient in terms of the evidence, and therefore is not recommended in the general population. 5-alpha reductase inhibitors are next, and they're looking specifically in the context of prostate cancer prevention. So the PCPT, you looked at finasteride as the 5-alpha reductase inhibitor of choice and found an absolute response rate of 6% at 7 years and a relative response rate of 24.8% at 7 years. However, even though the risk of prostate cancer decreased, the mortality has been unchanged. The dutasteride trial looked at the same thing and saw very similar incidence of, or decrease in the incidence of prostate cancer. And so we see an overall risk reduction is consistent regardless of which 5-alpha reductase inhibitor you use. However, overall survival has not been affected because of the grade. And what we see in those who develop prostate cancer on one of these medications tend to have a more aggressive, which is defined as Gleason score greater than 7 type of prostate cancer. And so the reduction in incidence is offset by the more aggressive cancers when developed. So as we go and look at the guidelines in that setting, you're going to see issues with that being a very big point of controversy. So next up is the infection-related methods, and I mentioned briefly back in the beginning of this presentation, hepatitis B vaccination. And what we've seen in some studies is that vaccination in younger patients reduced hepatocellular carcinoma incidence in young adults. And we see that there's a reduction of at least 50% in pediatric and young adult HCC with more regular hepatitis B vaccination. And so the guidelines do recommend or do state that universal neonate or neonatal immunization is predicted to eliminate about 70 to 85% of hepatocellular carcinomas globally. And so I think we're going to see more on that and more encouragement in that. We've already seen some guidelines for any of you who've had children. You probably had the recommendation to get the first hepatitis B vaccination at or near birth. Next is H. pylori eradication. So we do know that H. pylori is associated with certain types of cancers, especially in the gut, whether that be gastric cancer or multiple lymphomas. And studies have shown that treatment of the H. pylori infection may reduce risk of gastric cancer. And the combination of amoxicillin with a proton pump inhibitor has reduced the incidence of gastric cancers by about 39% at 15 years. However, it still has not statistically reduced mortality based on current studies. So, yeah, I mean, you're going to treat it anyway. You want to treat it. You may gain some benefit in reduction of cancer risk, but not to say that it's perfect. And then I wanted to point out a couple other interventions that I've tried and failed. Now, there's a lot more than what I have on this slide. And again, for more examples, I would recommend going to Table 5 within the handout or the content outline. So just some examples. So beta carotene, and I pulled this one out because the high intensity smokers who take pharmacologic doses of beta carotene actually have an increased risk of lung cancer incidence and mortality. In non-smokers, there's no impact, but really I called that one out because, you know, everyone, you often hear, well, it's not going to hurt. Well, that's not necessarily true. In some cases, some of these options will hurt. So that's one example. In terms of other examples, so selenium in terms of prostate cancer has no benefit. Vitamin E or tocopherol for prostate cancer, again, select trial that looked at various prevention methods showed a 17% increase in prostate cancer in the vitamin E alone group, but not in combination with selenium for some reason. So again, while that's not statistically significant, there is a trend, and we have to really weigh what the information is out there. And the statement, well, it's not going to hurt, it's a natural product, it's a supplement, it's not going to hurt, that's not true. And we really need to make sure to have that data to back up that statement when we address that with patients. So the summary of the prevention before we jump into the screening guidelines, which will be a much faster section, is it's really important to understand the risk factors, and that helps us with understanding the prevention methods, because if we understand what can cause it, addressing those things can help treat it. Some cancer types do have known prevention, others do not, but the approach still needs to be individualized to the patient. And it's really important that we address that I did everything right mentality when we talk about cancer prevention. Like I said, there are certain things that we don't know the risk factors or we don't know how to prevent it. And so I've had patients who come in and said, hey, you know, I lived a healthy lifestyle, I never smoked, I don't drink, but I still got cancer. I did everything right and I still got cancer. What was the point? Well, again, it's really important to note and talk to patients about the fact that that is not necessarily the case. There are other reasons, things that we don't know about, things that we may have never known we were exposed to that can still cause cancer. And it's really important to help patients dispel that mentality and improve their mentation going into treatment. There are many national organizations that provide guidelines on cancer prevention, as was discussed. And there are several pharmacologic methods that have shown promise in reducing morbidity and or mortality by reducing the incidence. Really, the biggest focus on cancer prevention is smoking cessation, UV protection, diet, and exercise, and those all should remain key priorities in cancer prevention. All right, so next up, moving on to cancer screening. So again, within this section in the slides, I really kind of tried to summarize. You're going to see a lot of tables. For all the data, please refer to the content outline for the specifics and information there. So starting with breast cancer, and breast cancer is separated into screening for the average risk population compared to the high risk population. So screening techniques, so you'll see guidelines from the American Cancer Society, NCCN, and USPSTF. And the only ones that recommend that breast self-exam and clinical breast exam are NCCN. And one of the major reasons for that, again, is because of the variability in breast self-exam as well as clinical breast exam in terms of the clinicians providing them. And what we know is, even though you probably hear a lot of stories about how patients discovered their own breast cancer, the reality is that BSE and CBE increase the risk of unnecessary biopsies, unnecessary scans and workup, and really have not been shown to have a benefit in overall survival in terms of breast cancer risk or mortality. Most guidelines do recommend mammograms, and the age of start is really dependent, but you're going to see most being fairly consistent, starting around the age of 40 with an annual or even biennial screening with mammogram. As patients get older, in certain age ranges, you'll see some different changes within the ACS, so recommendation versus do it annually, and then once they get to a certain age, maybe less frequently. USPSTF doesn't talk about those over the age of 75 having insufficient evidence for screening, and so most guidelines are going to say, once a patient passes the age of 75, there's really no reason for screening because of the mortality benefit goes away at that point. Oops. So NCCN screening for high risk. So again, this is a different population that is much higher risk, and you'll see a lot of these risk groups that were previously called out: lifetime risk greater than 20%, history of thoracic radiation, Gale model risk, age, BRCA positivity, or other genetic conditions like Li-Fraumeni or Cowden syndrome. So I'm not going to read through all this. I'm not going to go into all the details, but the key point is in patients who are high risk, you're going to see not only now pushing for breast awareness in terms of something like a breast self-exam, but you're going to see more frequent follow-ups in terms of clinical encounters, and then mammograms or even breast MRIs starting at an earlier age compared to the general population. So 40 there, here anywhere between 25 years of age or about 10 years if there's a familial risk within first diagnosis. So outcomes in the data looking at breast cancer screening, there was a meta-analysis commissioned by USPSTF, and they looked at annual mammograms and the incidence of breast cancer mortality. And what they found is that annual mammography reduces mortality from breast cancer in women aged 50 years and older. And when they segmented that into the age groups, so they looked at breast cancer deaths prevented with screening per 10,000 women. And so those in the 40 to 49, they saved 3 breast cancer deaths per 10,000. In the next decade, 8. And then in the 60 to 69 group, they actually were able to prevent 21. And that's a pretty big jump in terms of the other ranges. And so this is one of the reasons you see the guidelines from USPSTF that you see encouraging that higher and that closer follow-up in the age in the 6th or the 7th decade of life.
The next guidelines I would like to discuss is that of cervical cancer screening. While most major guidelines agree on screening recommendations, it is important to note that in 2020, the American Cancer Society updated their recommendations, and that changed those guidelines quite extensively. Now, we have not yet seen changes to the associated guidelines in those that endorse the old ACS recommendations. I believe that we'll be seeing that shortly. Currently, the USPSTF does have recommendations, which we will discuss, along with the ACS, ASCCP, and ASCP guidelines, which is the American Cancer Society, American Society for Colposcopy and Cervical Pathology, and the American Society for Clinical Pathology. The previous testing uses the Pap test as the most common screening tool, which has been proven to reduce both incidence and mortality of cervical cancer. Those who did not have screening had an incidence of 31 to 33 cases per 1,000 women, versus those who had routine screening only found reduced the incidence of cervical cancer to 5 to 8 cases per 1,000 women with that every 3-year cytology. They did find that co-testing for HPV DNA along with cytology had slightly increased the detection of early cervical cancer. Now, it is important to note that, again, in early 2020, a new primary HPV DNA screening test was approved by the FDA that received the indication that it could be used alone as the primary mechanism by which you could screen for cervical cancer through detection of HPV DNA. If we look at the current USPSTF recommendations, they break it down into age categories. Those less than 21 did not have routine screening recommended. Those in the 21 to 29 year range recommended cytology alone every 3 years. Those in the 30 to 65 year range recommended either HPV DNA and cytology co-testing every 5 years, which was the ACS preferred recommendation in the previous guidelines, or cytology alone every 3 years. Those over the age of 65 did not have recommended screening, provided they had appropriate past screening and no histologic abnormalities. If there were any abnormalities, they would be continued screening for a defined time period based on those abnormalities. Now, the new recommendations for the American Cancer Society, which, like I said, just came out in 2020, greatly simplified the recommendations, and a large part of that is because of that new primary HPV screening test. The new recommendations state that those in the age of 25 to 65 alone use primary HPV screening test every 5 years on those cervical samples. So as you can see, the recommendations have greatly simplified and reduced the time frame in which we monitor patients for cervical cancer.
Moving on to colorectal cancer. And again, this is broken down into average risk and high risk, or hereditary colorectal cancer. So again, starting these, and there's 5 different guidelines. So NCCN and USPSTF actually agree, even though they're separate guidelines, so they're combined here. But ACS, ASCO, USMSTF, which is a separate guideline specific for colorectal cancer, and the NCCN, USPSTF represent your 5 guidelines. So most recommend starting at 50. ACS is a little bit sooner. They tend to be the most liberal in their recommendations. And then most recommend stopping between 75 and 85 years of age. In terms of the method of screening, you can use any of the following. So you can either do annual FIT testing, which is fecal immunochemical test, or annual FOBT or fecal occult blood testing. Stool DNA can be an option. That's every 3 years. ASCO does recommend this as an option, but they actually put this as a very low-level recommendation. CT colonography can be an option. Again, ASCO listing this as a low option with low-level evidence every 5 years. And most of them you're going to see either recommending sigmoidoscopy or colonoscopy. And if you generally, since the sigmoidoscopy only covers a smaller section of the bowel, they recommend doing that every 5 years. However, if you do a colonoscopy, then you'll do it every 10 years. So again, there's some caveats within that. It's not important to kind of go through all that right now because of time, but I encourage you to go look at those deviations and those slight differences between the guidelines and where those things fit in terms of the full content outline. So again, like I said, high risk or hereditary colorectal cancers. So biggest things, you're going to see all these different genetic conditions. So family histories, and then FAP, which we mentioned, and then other genetic conditions that are mentioned here. Most are called out in the NCCN guidelines. So NCCN has its own guideline for high risk and hereditary colorectal cancers. ASCO or ESMO does have some guidelines for a couple of the situations, but really the focus is here. Again, the big difference here versus the general population is you're just going to be doing these colonoscopies. So again, primarily colonoscopy, sigmoidoscopy kind of goes out the window. But primary colonoscopy starting much earlier than you would see in the general population, either related to a certain age, such as juvenile polyposis syndrome, which recommends at 15, or in patients with family history, every 5 years starting age 40 or 10 years before the earliest family diagnosis. And the guidelines for this group do continue lifelong, and so they don't have kind of a cutoff like you see with the general population. Lung cancer is the next group, and their guidelines are pretty straightforward. And most guidelines are going to recommend a low-dose CT or low-dose computed tomography, and that's the only modality yet to be shown to reduce mortality. So there's the NLST, which is the National Lung Study. The Nelson trial and the MILD trial have all looked at the use of low-dose CT for reducing lung cancer mortality. So you see some slight differences in age range, as well as smoking history and how often they've quit. But what they found is across the board that low-dose CT can reduce lung cancer mortality in patients who are, quote, high risk because of smoking exposure. And so again, in the NLST study, you see a 20% mortality reduction. In the Nelson trial, much higher in women especially, so about 40% in women, and then about 20% in the MILD trial. So you look at those different guidelines and they recommend that. So what you're going to see in terms of the ACS recommendations is going to be matching the parameters found in the NLST trial, which is any patient aged 55 to 75 years of age with a 30+ pack year history and who's quit within 15 years is recommended to get the annual low dose CT. So again, looking at the guidelines, they all slightly different with this low dose CT. Again, most are going to say 55 to 75. It's a really good kind of in between, and most are going to say 30 pack years within 15 years of cessation. So once you get to 15 years post cessation, then you can stop the screening of the low dose CTs for lung cancer. Ovarian cancer does not currently have guidelines in terms of effective screening tests for ovarian cancer. They've tried lots of different things, but right now USPSTF recommends against screening asymptomatic patients with no risk factors because screening has shown to have no impact on mortality, and the risks associated with additional screening and the testing may dissuade use. NCCN does have guidelines for high-risk patients such as BRCA mutation or family history. They recommend following the CA-125, which is a tumor marker, along with endovaginal ultrasound. However, the guidelines do admit that there is no evidence that this affects the survival in this patient population. One of the things I wanted to talk about was the OVA1 test. This is a new test that looks at a group of test measures such as transthyretin, apolipoprotein A1, transferrin, beta-2 microglobulin, as well as CA-125. So this is a new test you'll see out there that's being promoted, but it's not really promoted by any of the organizations because it has yet to prove a benefit, and really these high-risk patients are going to be encouraged to undergo risk reduction surgeries, which has its own morbidity and mortality associated with it. And so you'll hear about the OVA1 test, but currently none of the major guidelines actually promote that use. Prostate cancer. So this one's a big one. This one's controversial. And the screening may reduce incidence or mortality, but the risks of overdiagnosis and treatment make long-term survival outcomes questionable. And so there are two screening modalities you'll hear about in the context of prostate cancer. First is the prostate-specific antigen, or PSA. And the problem with PSA is it has lots of false positives for multiple reasons. And again, you can read all about that within the content outline. It can also be altered by medications, so use of 5-alpha reductase inhibitor, saw palmetto, which is essentially a natural version of a 5-alpha reductase inhibitor, as well as androgen blockers can all alter the PSA levels, making it less reliable as an indicator. The other thing that's controversial is what's the goal level. So the specificity of PSA is only about 67% when that PSA is greater than 10. And so when it's less than 10, it has very low specificity. And that's where you see a lot of questionable gray area in the guidelines, as well as whether or not that really tells you anything. And so what we're seeing is a change in focus towards what's called the PSA velocity, or the rise over time. And so patients who have greater than a 0.35 nanogram per ml per year increase have been shown to have a higher relative risk of prostate cancer death. And so maybe more so than the absolute value, that PSA velocity may be more useful for prostate screening going in the future. The other thing that is used is the digital rectal exam. And again, most guidelines don't recommend this because it's all based on the practitioner that is administering it and the variability in assessment that can occur. So you see a lot of false positives and false negatives with DRE, and therefore you're going to see very low guideline recommendation on that one. So in terms of summarizing the current guidelines for prostate cancer screening, so these are the guidelines. So you have ACS, you have the AUA, which is the American Urologic Association, ASCO, NCCN, USPSTF. So again, you're going to average these out. Most start probably about 50 years of age. If they're high risk, you start up to 10 years earlier than that. Screening tests, again, across the board, PSA, and NCCN is the only one that currently recommends the DRE, but even then it's a weak recommendation. You can do it with or without, but you have to do the PSA. One of the things that we're seeing now is actually a decrease in frequency So rather than doing an annual PSA, the current guidelines recommend spacing that out anywhere up to 2 to 4 years between each test. And so again, that's if they're normal. If they have an elevated PSA, then NCCN and ACS at least recommend doing it more frequently. When do you stop screening? If you chose to start it in the first place, right? So again, all of these are say, if you choose to go for it. They all recommend this be a shared decision in whether to monitor between patient and provider. However, if you choose to go forward, generally you're going to stop either at age 70 to 75 or when the life expectancy due to comorbidities is to be less than 10 years. Because most prostate cancers are very slow growing, and as a result, most prostate cancers, not all, but most, do have a very low risk of prostate cancer death within 10-year time frame. So if a patient has multiple comorbidities that are more likely to take their life than prostate cancer would in the 10 years. That's why they set that cutoff. Skin cancer guidelines. So one of the things that's really important to note is that while I'm going to talk about recommendations for screening, the ACS and the American Academy of Dermatology don't actually have specific guidelines that say you should do X, Y, Z every so many years. But they both say, hey, it's probably not a bad idea to get a skin self-assessment with periodic clinician assessment as well. USPSTF does state there is insufficient evidence to support screening. However, if you go in, there's actually a really interesting commentary article that refers to the USPSTF guidelines and suggested that there may be high-risk patients that should undergo screening that were overlooked by USPSTF. And so while USPSTF suggests in the general population you shouldn't do it, there is some suggestion that, hey, if you have high-risk features or you have high risks, such as, light skin, red hair, blue eyes, those kind of features that are often included in that high-risk assessment, that maybe those patients should be screened on a regular basis. So if we do use screening, you probably heard the ABCD, and I think each time I've reviewed this in my history as an oncology pharmacist, they've added a new letter. And when I prepared for this, I actually found that there's some recommending ABCD, E, F. So F being funny looking, or what's called the ugly duckling sign. So there's asymmetry, A for asymmetry. So you can kind of see the difference in this thing here, in this picture here, nice and round here, asymmetric, kind of one side being different than the other. Border is irregular, so nice clear borders here in benign, very irregular here in the malignant form. Colored, nice and uniform in a benign, mixed in a malignant, and then diameter. Larger than 6 millimeters are kind of one of the best ways I've heard it described. It's larger than a pencil eraser head, for those of us who still have those. The diameter, if you place the kind of the pencil head on it and it exceeds that size, that's when you get kind of beyond that 6 millimeter range. And then E is evolves over time, so they follow a suspicious looking lesion and it tends to evolve over time. This is the concept behind mole mapping, although that has become a little controversial. So F, again, the new one, the funny looking or the ugly duckling sign. It's any nevus that's different from others on a given patient or is more suspicious for malignancy. So it kind of throws in that clinician judgment piece, which in other diseases, we've talked about how clinician judgment may be a little controversial in the screening recommendation, but hey, it's here. Again, you're not going to see this in the guidelines, but it's a separate article that is suggesting that be included in your assessment. And then I wanted to point out this one. So there's the genetic or familial syndrome screening. So patients who have specific genetic testing variants indicate that there are known risks for several cancer types. And so NCCN actually has a really good guideline that outlines associated cancer types and the screening recommendations. So again, I'm not going to go into all the details on this, but see the previous cancer type screening recommendations that we talked about, as well as these guidelines and the information in the full content outline. But what I want to look at is these are the various genetic mutations that are called out within the guidelines, and those diseases that are underlined are very clearly defined as an association between the gene mutation and the increased risk of cancer. And those that are not underlined, there's an increased risk that's possible, but the data are currently insufficient to link definitively. Again, I'm not going to go into the details of how you screen for each of those. They generally put these patients into those higher risks, and therefore they're going to be seeing issues with these patients going in and needing more frequent or much sooner follow-up compared to the general population. So the last thing I wanted to talk about today is the ACS 2035 goal, or the 2035 challenge goal. And what they did is that they kind of put together this research group called the Cancer Mortality Reduction Research Group. And their charge was to review and address disparities in cancer care progress. And one of the things the parameters they were tasked to look at included race disparities, ethnicity, region of residency, socioeconomic status, and those kind of parameters that we know are associated with disparities in both cancer screening, prevention, and incidence. And based on their studies, they were to set goals and recommend projects to improve screening and prevention. So the potential benefit of current screening and prevention, so it's estimated that cancer death rates will decline by 26.4%, and more so in men than women, unfortunately, but that's just what their information has found. They looked at lung, colorectal. They found that lung, colorectal, female breast, and prostate cancer will decline substantially, and that accounts for about 50% of all cancer deaths, which represent the main driver for decline. Liver, pancreatic, and uterine cancers were all suggested to increase if nothing changes based on the results of this evaluation. And what they did find was that reduction in cancer death is steeper overall in those with at least a college degree. And so it's estimated that if major risk factors decrease and screening rates among Americans can reach the level of college graduates by 2025 to 2030, there will be an additional 20.5% drop in overall cancer death rate by 2035. So in other words, currently we're estimated 26.4% reduction in cancer death rates. If we can increase the screening and risk factor decrease as mentioned, we can add 20% of that. So we're looking at almost a 50% potential decrease in cancer incidence and mortality by the year 2035. So really something that I thought was important to highlight and encourage and push for, and thus going back to what I said about why we should do more as pharmacists and healthcare providers and oncology providers in focusing on cancer prevention, not just treatment. So to summarize, there's several screening and prevention methods have been definitively proven to reduce cancer incidence and mortality. For a summary of those guidelines, I would encourage you to go to Table 13 in the screening and prevention content outline. There's still huge disparities in the ability to reduce cancer risk and effectively screen per the recommendations, and more work is needed in screening and prevention parity for the patients as was brought out by that ACS 2035 challenge. A lot more research focused on screening and prevention methods is needed, and I think this is an opportunity not just for oncologists or primary care providers, but us as pharmacists in being able to contribute to that information, whether it be through clinics or smoking cessation, vaccination clinics, what have you, and what we can do to make sure that we educate enough people to help them understand what their risks are and how we can prevent them. And most importantly, the guidelines are changing frequently, so keeping up can be hard. This is one area that, some of the guidelines as I work through this program changed 3-4 times over the course of my development of this material, and will probably change a lot more in the next few years. And so really important that we keep up on that and we keep watching for that going forward. So that's all I have. I want to thank you all for listening in on the cancer screening and prevention lecture. If you have any questions, please refer to the detailed information outlined in the full content outline. There's much more information there than what I was able to cover in the time frame of this webinar. So again, I appreciate, hopefully I've proven the point that screening and prevention is important, and going forward that this helps in preparation and understanding of the other disease states as well. Thank you for your time.